So imagine waking up from major abdominal surgery.
Oh, man.
Right. You're covered in stitches, your core muscles have basically been surgically reorganized, and, your brain is totally foggy from the drugs.
Yeah, and your body is just absolutely screaming at you to lie perfectly still.
Exactly. And then the absolute first thing the recovery nurse tells you to do, and I mean immediately, is violently cough.
Which is, it feels completely counterintuitive, right?
Totally.
Because protection usually equals survival in our minds. But that immediate post-operative window, it forces this bizarre biological compromise that totally overrides all of our natural instincts.
Right. And for those of you listening today, whether you're, prepping for a procedure yourself, caring for someone, or you're just insanely curious about human biomechanics, we were taking a deep dive into some standard hospital guidelines and recovery manuals.
Yes, we are.
And the mission today is to answer a surprisingly complex question. How soon after treatment is coughing or straining a concern?
It's a great question, and the timeline is wild.
It really is, because we found this bizarre paradox in the sources. In the immediate aftermath, on day one, coughing is literally a mandatory lifesaver.
Yeah, you have to do it.
But then weeks later, long after you'd assume the danger has completely passed, that exact same cough becomes the thing that could permanently destroy your surgical repair. So, okay, let's unpack this.
Yeah, to really understand that paradox, we have to look at the biomechanics of the human body under anesthesia.
Right.
Because when a patient undergoes general anesthesia, the normal automatic defense mechanisms of your respiratory system, they just shut down.
Wow.
Completely. The volatile anesthetics essentially paralyze these tiny hair-like structures in your airways called cilia.
Okay, the cilia.
Right, and normally they're constantly sweeping debris and mucus upward and out of your lungs.
So basically, the body's natural conveyor belt for clearing out the lungs just stops working entirely.
Entirely, yes. And if you combine that ciliary paralysis with the fact that the patient's natural gag and cough reflexes are chemically suppressed.
It's the anesthesia, right.
Exactly. Plus, they're lying completely immobile for hours. Well, this creates a scenario where mucus and fluids rapidly pool in the lower gravity-dependent lobes of the lungs.
That does not sound good.
It isn't. What's fascinating here is that if that pooling is left in the warm, moist environment of the chest cavity for even a short period, microscopic areas of the lung actually collapse.
Wait, really? Like actual lung collapse?
Yeah, it's a condition called microatelectasis. And that stagnant fluid becomes the ultimate breeding ground for post-operative pneumonia, which, can be fatal.
Okay, wait. If the risk of respiratory failure and pneumonia from general anesthesia is that severe within hours of waking up, why use general anesthesia at all for lower body or pelvic surgery?
That's a really good point.
Right. Like, why not just use a spinal block similar to an epidural so the patient's lungs are never compromised in the first place?
It's a crucial question. And honestly, for simpler procedures, regional anesthesia is absolutely preferred for exactly that reason.
Okay. So why don't they always use it?
Well, for major abdominal or complex pelvic floor reconstructions, these are procedures that can take 3 to 5 hours.
Oh, wow. Yeah, that's a long time.
Right. And surgeons require complete muscular paralysis of the abdominal wall. A spinal block just cannot safely provide that level of prolonged, high abdominal motor block without risking paralysis of the diaphragm anyway.
Oh, I see.
Furthermore, the positioning required for these surgeries, often with the head tilted drastically downward, it makes protecting the airway with an endotracheal tube totally mandatory.
Wow. Okay, so you are trapped making a devil's bargain here.
Yeah, you really are.
You have to shut down the lungs to fix the pelvis, which means the moment the patient wakes up, the immediate threat to their life isn't the giant surgical wound.
No.
It's the impending lung infection.
Exactly. And that biological reality dictates the entire immediate post-operative protocol. The danger to the lungs is so acute that hospitals mandate aggressive deep breathing and coughing exercises starting the second the patient is conscious.
The literal second.
Yes, they aim for 1 to 2 sets every single hour you are awake for the first 2 to 3 days.
Honestly, that just sounds like torture. We are talking about patients who just had their fascial tissue sliced open.
I know.
And a full cough generates massive intra-abdominal pressure. To me, it's like being told to aggressively rev the engine of a car that's just been in a front-end collision just to clear the exhaust pipe.
That's a great analogy.
So how on earth do patients do this without ripping their fresh incisions to pieces?
Well, the clinical protocols detail a highly specific mechanical approach to this. First, the patient is instructed to sit upright and bend their knees.
Why bend the knees?
Bending the knees mechanically shortens the abdominal muscles. It introduces a slight slack into that fascial layer, which, reduces the baseline tension on the sutures.
Oh, clever. Okay.
Yeah, and then comes the physical bracing. The patient must hold a rolled-up towel or a firm little pillow tightly over the incision site.
Just literally holding it against the wound.
Exactly. By applying a localized external counterpressure, they artificially brace the abdominal wall against that sudden internal pressure spike of the cough.
Ah, so it's essentially putting a heavy clamp on a pressurized pipe before you turn the water on.
Yes, perfect way to put it.
Yep.
And they don't just do a standard cough either.
Right. The sources mention this. The manuals detail a technique called the huff and cough,
Yeah, the huff and cough.
where you take a slow, deep breath, and instead of closing your throat and popping it open like a normal cough, you leave your glottis open and forcefully exhale.
Like you're trying to violently steam up a bathroom mirror.
Exactly.
The biomechanics of the huff are brilliant, honestly, because a closed glottis cough creates a massive explosive pressure spike that tests the absolute limits of the surgical repair.
Right.
But the open glottis huff uses sheer airflow velocity to drag the pooled mucus up the bronchial walls without that dangerous pressure spike.
That makes so much sense.
And once the mucus is moved higher into the larger airways, a single, highly supported, controlled cough is usually enough to finally expel it.
Okay, so for the first maybe 72 hours, the upward pressure of the lungs demands your full attention.
Yes.
But as soon as that acute respiratory danger passes, the biological focus violently shifts downward.
Oh, big time.
Right, because from the moment the anesthesia wears off, straining of any kind, specifically downward pelvic pressure, is treated as the absolute enemy of the recovery process.
Yeah, the anatomy of these lower abdominal and pelvic reconstructive surgeries explains that sudden shift in priorities. Let's focus specifically on pelvic organ prolapse repairs for a second.
Okay.
The pelvic floor is this complex matrix of muscle and fascial connective tissue.
Yeah.
It doesn't just sit there. It's a dynamic biological hammock.
Right, holding everything up.
Exactly.
Yeah.
It actively holds up the bladder, the bowel, the uterus against the constant, unrelenting downward force of gravity.
And when a patient requires surgery for a prolapse, it means that fascial hammock has physically failed,
Yeah.
right?
Yes, exactly.
The connective tissue has torn or stretched out, allowing those internal organs to physically slide down. So the surgeon is literally pulling those organs back up and anchoring the delicate tissues back together to recreate the support.
Which means any deliberate intra-abdominal straining like, say, bearing down to open your bowels, acts like a battering ram against that fresh repair.
A battering ram.
Yeah. A strong bearing down motion channels the entire weight of the abdominal organs directly into the pelvic floor. It forces those fragile new sutures to bear a massive load they simply aren't ready to handle.
But wait, looking at these clinical protocols, it reveals an absolute maddening catch-22 for the patient.
Oh, the pain meds?
Yes. The sources heavily emphasize that we need to take pain medication to comfortably perform those mandatory coughing exercises we just talked about.
Right, you can't cough if you're in agony.
Exactly. But those exact painkillers, especially opioids like oxycodone or codeine, they are universally notorious for causing severe constipation,
They absolutely are.
which directly leads to the downward straining that we are explicitly forbidden to do. So how do we win here? I mean, how is a patient supposed to navigate a scenario where the cure for one problem mathematically guarantees the onset of the exact thing that will ruin the surgery?
It's tough. If we connect this to the bigger picture, it requires a highly choreographed intervention.
Okay.
To understand the solution, you kind of have to understand the mechanism behind opioid-induced constipation.
Right. Why does it happen?
Well, the human digestive tract is governed by the enteric nervous system. Opioids bind to the mu-opioid receptors that are densely located all throughout the gut.
Okay.
When those receptors are activated, two things happen simultaneously. The rhythmic muscle contractions that move food along, which is called peristalsis, they grind to a halt.
Oh, no.
And at the same time, the intestines dramatically increase fluid absorption.
Oh, I see. So it's like turning off the conveyor belt in a factory, but leaving the dehydrator running on maximum power.
That is a highly accurate and slightly horrifying way to visualize it.
Yes. The stool literally just stops moving and turns into concrete.
Exactly. And because the resulting constipation requires massive physical straining to resolve, relying heavily on opioids becomes a direct anatomical threat to a pelvic floor repair.
Right.
So the modern clinical strategy circumvents this by attacking the pain through multiple non-opioid pharmacological pathways simultaneously.
So it's a cocktail approach. rather than relying on one heavy hitter.
Precisely. The protocol involves aggressively staggering NS-ANDAs, like ibuprofen with acetaminophen.
Okay, stagger them how?
Well, ibuprofen reduces inflammation at the actual tissue site,
Mm.
while acetaminophen elevates the body's overall pain threshold centrally in the brain.
Oh, I didn't realize they work differently.
Yeah. By taking them on a strict, overlapping schedule, say acetaminophen at 8 a.m., then ibuprofen at 11 a.m., acetaminophen again at 2 p.m., the patient maintains a constant overlapping shield of pain relief.
Without ever touching those opioid receptors in the gut.
Exactly. You stay continuously ahead of the pain curve, and you reserve the opioids only for severe breakthrough spikes.
That's smart. But the pharmacological staggering is only half the strategy, according to the sources.
Right.
The other half involves aggressive dietary and biological hacks to keep the digestive tract moving without any muscular effort from the patient.
Yeah, the goal is zero-resistance digestion.
Right.
The clinical manuals are so adamant about this. Patients must consume 1.5 to 2 liters of water daily. They have to implement a high-fiber diet immediately and begin taking prescribed laxatives or stool softeners from day one.
Like long before they actually feel constipated.
Yes, you take an osmotic laxative, which draws water back into the colon, reversing that dehydrating effect we just discussed.
Because you cannot wait until you feel backed up to take action. By then, the physical damage required to clear the blockage will likely compromise the surgery.
Exactly. You have to be proactive.
There is also this fascinating biological trick listed in the postoperative manuals for dealing with trapped wind, because gas also severely increases intra-abdominal pressure, right?
Oh, yeah. Trap gas is incredibly painful post-op.
The guidelines actually recommend drinking peppermint water or chewing peppermint gum.
I love this part. The peppermint gum protocol is just a fantastic manipulation of human physiology.
How does it work?
It leverages the cephalic phase of digestion.
The cephalic phase.
Yeah. The mere act of chewing and tasting something stimulates the vagus nerve. And that tricks your brain into thinking a large meal is incoming.
Oh, wow.
So the brain immediately signals the stomach and the intestines to wake up and clear out the current contents to make room.
That is wild.
Right. It jumpstarts peristalsis, allowing the bowel to contract and move that trapped gas along naturally, completely bypassing the need for the patient to physically bear down.
That is incredibly elegant. You're just tricking the autonomous nervous system into doing the heavy lifting for you.
Yep.
So the guidelines establish the mechanics of what pressures to avoid. We know we have to hack our nervous system to avoid downward pressure while artificially bracing our core to handle upward pressure. But the ultimate question for any patient looking at this recovery timeline is, how long do you have to live in this state of hypervigilance?
Yeah, that's the big one. And to answer the timeline question, we have to zoom in from the macro mechanics of coughing and digestion down to the microscopic cellular reality of wound healing.
Okay.
And the biological timeline is drastically slower than our modern intuition expects.
I have to say, this was the most jarring realization in the entire stack of medical literature.
Really?
Yeah, because we are conditioned to think of healing in terms of a week or two, right? You get a cut, a scab forms, the scab falls off, and you assume the tissue is fully repaired.
Right.
But the surgical texts highlight a terrifying statistic. At the time, external stitches are typically removed, usually around that 7 to 14-day mark. The tensile strength of that repaired tissue is only at 5% of its normal capacity.
5%.
That's it. The external appearance of a closed wound is nothing more than a biological illusion.
During those first 2 weeks, the body is in the inflammatory and early proliferative phases. It has essentially just glued the edges together with a very weak, haphazard scaffolding of collagen. It hasn't yet begun to build the structural integrity required to withstand actual physical force.
Here's where it gets really interesting. It is exactly like gluing the handle back onto a heavy ceramic coffee mug.
Oh, that's a perfect analogy.
Right. Because at week 2, the glue is dry to the touch. You can pick the mug up by the body, run your finger over the crack, and it looks perfectly fine.
Yep.
But if you actually try to use that handle to lift a cup full of hot coffee, the weak adhesive will instantly shatter under the weight.
That perfectly captures the danger of that proliferative phase of healing. The tissue looks intact, but it possesses basically zero load-bearing capacity.
Right.
And unlike highly vascular tissues like your tongue or a muscle belly, which have massive blood supplies and heal super quickly, the fascial matrix of the pelvic floor has a relatively poor blood supply.
Oh, so it just takes longer to get the building blocks there.
Exactly. The cellular process of replacing that weak collagen with strong, highly organized collagen takes an incredibly long time.
The timeline is staggering. The guidelines state that at 6 weeks post-op, the internal repair is still only about 70% healed.
Yeah.
The internal dissolvable stitches used to anchor these structures don't even fully vanish for 4 to 6 weeks.
Yeah.
Sometimes they take up to 3 to 6 months to break down.
Right. The biological remodeling phase takes a minimum of 12 weeks, 3 full months.
Wow.
It isn't until that 12-week mark that the primary healing phase is considered mechanically complete.
Which totally reframes the lifting restrictions that hospitals send patients home with, because when you first read them, they sound almost comically extreme.
They do.
The recovery protocols specifically mandate that for the first several weeks, a patient should not lift anything heavier than a full kettle of water, or even half a kettle.
Yeah, a standard full kettle weighs roughly 2 to 3 kilograms. Lifting even that tiny amount of weight requires your core to brace, which generates just enough intra-abdominal pressure to severely threaten a repair that's hovering at 5% tensile strength.
And the restrictions continue long after the patient subjectively feels totally fine.
Yes, they do.
By the 6 to 12 week mark, when the patient likely has no pain and feels completely normal, the hospital explicitly warns that they should lift no more than the equivalent weight of 6 cans of beans.
6 cans of beans.
Think about the sheer impracticality of that in daily life.
It's basically nothing.
Navigating a modern grocery store with a limit of 6 cans of beans, forget about it. Pushing a heavy shopping cart, forbidden. And if you have a toddler who runs at you and demands to be picked up, you are strictly barred from scooping them up.
The recovery forces a fundamental psychological shift in how the patient interacts with the physical world. You just cannot rely on pain as an indicator of safety anymore.
Because it doesn't hurt, but you're still fragile.
Exactly. You have to ask the toddler to climb onto the sofa next to you. You have to divide your groceries into a dozen tiny light bags.
Right.
The patient has to become a full-time manager of invisible vectors of pressure.
It is a massive cognitive load. So, okay, let's project into the future.
Okay.
A patient acts perfectly. They stagger them on opioids, they chew their gum, they brace their coughs, and they never lift more than 6 cans of beans for 3 solid months.
The perfect patient.
Right. They hit month 3, month 6, and the biological remodeling phase is complete. When do they finally get to stop worrying about coughing and straining and go back to living without restrictions?
Well, this is perhaps the harshest biological reality found in the clinical literature.
Okay.
The answer to when you can completely stop worrying is never.
Wait, never. That is a heavy word.
It is definitive, unfortunately, because it's grounded in cellular mechanics. When human fascial tissue tears and is repaired, the body patches the defect with scar tissue. Even under optimal conditions, after a year or more of remodeling, that cross-link collagen scar tissue will only ever regain a maximum of 80% of the original tissue's innate tensile strength.
So the reconstructed pelvic hammock is permanently, mathematically, 20% weaker than the native tissue you were born with.
Yes, it will never be as resilient as undamaged fascia. And because the pelvic floor is uniquely subjected to that constant, unrelenting downward pressure of gravity, every single second you are standing upright.
It's always being tested.
Exactly. That 80% strength ceiling is continuously being tested.
Well, that structural deficit totally explains the incredibly high recurrence statistics we see in the sources. The data states that up to 30% of women, nearly 1 in 3, who undergo pelvic organ prolapse surgery will eventually suffer a recurrence of the prolapse.
It's a huge number.
Right. The repair itself might hold, but a different adjacent part of the wall gives way under the redistributed tension.
Which is why the postoperative advice eventually transitions from acute surgical recovery rules to lifelong lifestyle mandates.
Right.
The patient is no longer just protecting dissolving stitches. They are managing the mechanical fatigue of a permanently altered biological structure.
The long-term protocols specifically hammer this point home regarding chronic coughing. They frequently cite a smoker's cough, but obviously the threat applies equally to poorly managed asthma or, any long-standing respiratory issue.
Absolutely.
Every single cough acts like a microscopic hammer strike against the pelvic floor. Over years, hundreds of thousands of those microscopic pressure spikes will inevitably stretch and fatigue that 80% strength repair until it simply fails.
It's identical to the mechanical fatigue of repeatedly bending a metal paperclip. Eventually, the structural integrity just yields.
Yep.
So the guidelines are unequivocal. If a patient develops a chronic cough years down the line, they cannot just tough it out. They must seek prompt GP treatment immediately to protect their pelvic floor.
And the lifelong management extends beyond just coughing.
Right.
Long-term weight management becomes a vital necessity because every extra pound adds continuous downward force.
Yeah.
And the sources mention that some surgeons even advise their patients to adopt a permanent lifelong lifting restriction of 3 kilograms, about 6 pounds, just to prevent the recurrence of the prolapse.
The ultimate takeaway is that reconstructive surgery does not grant the patient a bionic pelvis. It merely resets the mechanical clock.
Right.
The exact same forces that caused the native tissue to fail in the first place, heavy lifting, chronic straining, intense pressure, will absolutely cause the reconstructed tissue to fail if the patient returns to their previous habits.
So to bring this entire timeline together for you listening, you go into major abdominal or pelvic surgery, and you wake up to a world governed by intense contradictions. In the first 72 hours, an explosive cough is your absolute best friend to save your lungs, requiring you to physically brace your incisions just to breathe safely. But weeks later, a chronic cough or a single severe bout of constipation becomes your absolute worst enemy for the rest of your life. And it all stems from the reality that your body is relying on a biological scaffolding that takes months to dry and permanently maxes out at 80% strength.
It's wild, but understanding these underlying physiological mechanisms, from the cilia in your lungs to the mu-opioid receptors in your gut, it transforms a list of frustrating hospital rules into a logical, highly predictable map of human healing.
It really does. Whether you are prepping for a procedure, caring for a loved one, or just fascinated by the sheer complexity of our biology, knowing the why behind the rules changes everything.
It really does.
When you understand that at 2 weeks your internal tissue is operating at 5% capacity, refusing to carry the laundry basket doesn't feel like you're giving up. It feels like you are actively executing a critical phase of your own recovery.
Exactly. It replaces blind, frustrating compliance with informed, active participation. But, surveying the sheer timeline of this biological fragility leaves us with a rather provocative final thought.
Oh, yeah, what's that?
Well, we currently rely on incredibly advanced, multi-million-dollar surgical robotics and highly specialized anesthesia to perfectly reorganize our internal anatomy, right?
Right, the tech is amazing.
Yet, the long-term success of that entire endeavor still relies entirely on the archaic, frustratingly slow, and permanently flawed healing mechanics of human collagen.
Wow, yeah.
So it begs the question, will the next great leap in surgical science be moving away from biological healing entirely? Will we instead synthesize biocompatible materials that instantly mimic 100% of human tissue tensile strength, rendering these months-long recovery periods completely obsolete?